Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. If you like any of our videos, do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notification of any future uploads.
Okay, thank you very much, Manoj. Let's start with my presentation. Try and share my screen. This aside. Okay. Right, I'm Kenneth Sheah. I'm a radiologist, but I also do ultrasound-guided injections in the lumbar spine. So this is eminently relevant to me as well. And I thank Miguel and Dr. Bernard for their excellent lectures. I also want to credit my other friends who've helped me on this journey. Dr. Edso, a radiologist who's presented at ISSPS before, Dr. Victor Chi, who is a fantastic anesthetist, and of course, Manoj himself. And I'll be showing you some images, trying to build on the giant shoulders of Dr. Bernard and Miguel with images of the lumbar spine on CT and MRI. So we're going again from dorsal to ventral, and we'll talk about the osseous anatomy, what we can see on our imaging, ligament anatomy, the dura, the meninges, the spinal cord, and then we'll mention a little bit about the subdural space. So firstly, with CT scan, you can get really thin cuts, sub-millimeter, usually 0.6 millimeters, and then you can reconstruct that into sagittal and coronal images. But what's really in practice are the axial images. And so I'm going to show you some real-life images here. So this you can see is an axial image of the L4 vertebral body. We just take this as L4, and usually you get this scout image. Okay, so you don't get a nice sagittal reconstruction usually when you're trying to do, say, CT guided injections. You have to use this and a red line to tell you where you are in relation to the vertebral body. Now, remember what Dr. Bernard said. The pedicles are attached on the superior aspect of the vertebral body over here. And that's why when you see us doing, say, vertebroplasty or lumbar augmentation procedures, the needles usually take an oblique tract along the transpedicle route from superior to the inferior portion, like that, because of the location of the pedicles. So on this axial image, we can see the spinous process. We can also see the laminae of the lumbar spine and then the transverse processes as they come down on both sides. This is the L4 spinal canal, the bony margins of the spinal canal, and then the vertebral body. You can see the erector spinae muscles, and they're defined by fatty strands within the intermuscular as well as the intramuscular spaces. Note the orientation of the pedicles in an oblique projection. And now we're moving slightly below the pedicle. And now you see the appearance of the exit foramen. So this is the level of the exit foramen below the pedicles. You will still see a little bit of the spinous process if you're scanning directly perpendicular to the floor, as we do with the CT scanners. So the spinous process follows down into the lamina, and then from there, the appearance of the exit foramen with the nerve root not seen at the moment. That's the vertebral body. Spinous process, lamina. Come down one more level, and then you start to see the appearance of the facet joints. And you are now in the interspinous space. So on the top here, if we follow Dr. Bernard's lecture, this is the supraspinous ligament, and then it flows down into the ligamentum flavum, the two limbs of the ligamentum flavum as they traverse the interlaminar space, and then the facet joints over here, and then the disc level. So at the disc level, this is a very characteristic appearance. We are right over the intervertebral disc here. It's dark, there's loss of bone. You can see some margins of the bone on the side, but the nucleus pulposus is dark because it is not calcified. Coming back again, you can see the ligamentum flavum, the thick limbs of the ligamentum flavum, the small epidural space in the back here, and then the spinal canal containing the spine, the thecal sac, and the CSF. So there is potentially, if on a CT-guided injection, a space where there is no traversing bone through which you can place a needle in the midline, straight down between the two limbs of the very tough ligamentum flavum into the epidural space to get an epidural injection. We move down again, one more level. Now at the superior end plate, you're starting to see the nucleus pulposus disappear, the superior end plate, and showing you the inferior articular process of the lumbar vertebra above, L4, and the superior articular process of the lumbar vertebra below, L5. And these form the facet joints. And now you start to see the spinous process appearing again. So that window, that interlaminar window or interspinous window is very small. And it gets even smaller as you go higher up in the lumbar spine, where you see the lumbar lordosis reducing the interspinous distances. Again, you see the spinal canal at the L4, L5 level here. Superior articular process. And now we come back down to the level where we started, the spinous process, the laminar, the pedicle of L5, and the transverse process over here. And you can see as how triangular that spinal canal shape is now compared to L4. So always bear this in mind as you're doing your cases. Now, not all our patients come to us with CT scan, and most of them will have some kind of MRI before we do any intervention. Now, let me just quickly orientate you with regards to the different sequences on the lumbar spine. The important thing here is to pay attention to the fluid, the CSF signal around the spinal canal, around the spinal cord and the cauda-equina nerve roots. If it's bright, then we call this a T2 weighted scan, which means it's weighted along the T2 properties of fluid. So fluid is bright. And you can see the urine within the urinary bladder being bright as well. Now, a T2 scan also picks up fluid within fat cells. And that's why you can see that fat within the subcutaneous tissues around the viscera of the abdomen and pelvis is bright as well. A T1 weighted scan is the opposite. The fluid around the spinal canal and within the spinal canal, around the spinal cord and the cauda equina is dark. And the urinary bladder signal is also dark, but fat signal is bright. Okay, so the key to recognizing what sequence you're looking at is fluid. Pay attention to that. T2, this one is T1. And if we want to be very, we want to focus down on fluid signal alone, we will then apply a fat suppression sequence. In this case, an inversion recovery or a stir sequence. So this gets rid of the signal from the visceral fat and the subcutaneous fat, as well as signal within the marrow itself, bone marrow fat, leaving us with nice signal within the discs, allowing us to pick up desiccation within an intervertebral disc, allowing us to detect bone marrow edema or Modic type 1 end plate change in the paravertebral end plates, which may independently be pain generators themselves. It also allows us to analyze the degree of disc protrusion, and it is well contrasted against the CSF signal within the spinal canal. So then I ask you, what is this last image? The signal of the fluid is dark, but everything else looks dark. Bladder, dark, subcutaneous fat, dark, but there are these bright areas here, and these are the basivertebral veins, and these are vascular structures which are now bright. And the only way we can get that to happen is if we give them contrast. So this is a post-contrast T1 weighted fat suppressed scan. T1 weighted fat suppressed contrast scan. Okay. Now, again, the most relevant for us is the axial anatomy. But before we go there, remember that you can, like Dr. Bernard said to us, you can get scoliosis. So you always have to bear this in mind. But remember the very oblique and inferiorly projecting course of the nerve roots as they come, as they emerge from the lumbar spine exit foramina. And this separates the lumbar spine anatomy from the thoracic spine anatomy as far as nerve root course is concerned. And we'll speak about that in 2 weeks' time. But for now, just remember that the lumbar nerve roots take a very oblique course inferiorly. And so if you put a needle beneath a pedicle here, you are in a relatively safe space than if you were more inferior and lateral, because then you run the risk of your needle coming into contact with the nerve root itself. Now on to the axial scan itself. Here, let me just take you through the sagittal very quickly. The supraspinous ligament, the spinous process, we're in the midline, and then that space there is subtended by the interspinous ligament. Before that, then you come through into the very tough ligamentum flavum, and then the epidural space, which usually contains fat. Now, what do we see on the axial scan correspondingly? Here is the tip of the spinous process. Remember that sometimes the MRI axials don't completely register accurately with the sagittals. For some reason, there's always a little bit of a shift. So you have to build a mental model internally. But here's the tip of the spinous process. And you come down, you can see that whole dark unit of the ligamentous unit, the interspinous ligaments flowing down into the ligamentum flavum on both sides, the two beautiful thick limbs of the ligamentum flavum. And then the facet joints, the top of the facet joints just emerging, and the transverse process over here. Sorry, let me just revise that a little bit there. Okay, and then we're moving downwards a little bit. Now, just below the pedicle where we were again, you can see the nerve root coming in. This is very medial, and the nerve roots are still very safely tucked away deep to the facet joints over here, still protected. The lamina, and then the spinous process over here. Coming downwards a little bit now at the disc level, you can recognize that appearance again. Just invert that CT image I told you about. This is fluid within the disc, the annulus pulposus, and then the nucleus pulposus, and then the annular fibers, which are devoid of fluid surrounding it. Look at the ligamentum flavum, again, at the level of the facet joints, and the nerve roots just about emerging now inferiorly. Now, the sagittal anatomy is also important for us to go through before we perform any of these injections. You want to identify the pedicles first. Remember how the pedicles are attached to the vertebral bodies on the superior half, leaving a large notch down here for the nerve root to emerge. And we're now at the level of the lamina itself, and you can see that the inferior articular process and the superior articular process of the facet joints forming a facet joint over here. Now, here's a very real world limitation of MRI. Sometimes the images are cut. The cuts that we get are too thick. It doesn't allow us to see through the interlaminar space as clearly as you would with an ultrasound beam. Remember, the ultrasound beam is at most about 1 to 2 millimeters in thickness, whereas with the MRI scans that we get, this is already 3 millimeters, which already, with one pass, would easily cover the interlaminar space. So you don't always get a perfect image. And here you see it has jumped from just about lateral to the interlaminar space directly onto the spinous process and in the midline, where you can see the spinous processes here, the supraspinous ligament, interspinous ligament, and then the epidural space right here in the midline. Okay, so this is real world stuff. You don't always get picture perfect images, but it's worthwhile to go through them to identify how much space you have to maneuver. Now, I draw your attention superiorly now, because at L5, the canal is slightly narrowed and tapered down, but as you go slightly higher up, you get more and more space within the spinal canal. The epidural space increases in size, and you can start to see the dura and the arachnoid layers coapted together to form the nice boundaries of the thecal sac over here. Beyond this is the spinal canal. So epidural space, dura, and arachnoid, and then the subarachnoid space where you would be performing a spinal tap, for example. Remember, the conus medullaris is usually terminating between L1 and L2 levels. And that's why people are now increasingly considering performing safer spinal taps lower down in the spine at L4 and L5. But this in itself presents challenges, which we will discuss in a minute. For those who want numbers, the epidural space is usually around 7 millimeters wide in the midline, in the lumbar region, but then it starts to narrow down inferiorly as well. Okay, and now I just want to shift us to the MR workstation, try and see if we can identify some images there. Just give me a second. Okay, I have two images here to share with you. And now you can see the MRI side by side. This is a 39-year-old patient, and the 39-year-old patient has a large lumbar disc which has extruded inferiorly and caudally. And you can see how it's starting to deform the spinal canal. And this needs to be borne in mind if you were to perform any spinal procedure. A deformed thecal sac is not one where you would want to place your needle in, because the anatomy is completely distorted. And the assumptions that we make during paravertebral and central neuroaxis sonoanatomy can be distorted along with it. So you have to be careful. So now, if you can see, I'm scrolling down the axial scans. This is 5, 4, 3, 2, 1, and then T12 level. At T12, the spinal canal is nice and cylindrical, round in shape. The tip of the conus medullaris and then the cauda equina nerve roots starting to emerge. Scroll downwards again, and you can see the spinous processes, the lamina, the transverse process, and the pedicle. This is at L1 level. Still very circular in shape. Scrolling downwards again, the exit foramina start to appear together with the facet joints. So when you see facet joints appearing, you can be fairly sure that you are at the level of the exit foramina if your scan plane is parallel to the disc. And that's a very big if, because in ultrasound, sometimes we can have some cranial caudal tilt of the probe, and that can distort the axial plane as well. So it's important while you're going through the MRI just to build a mental picture of what the whole thing will look like on ultrasound. Slowly scrolling down from L1 down to L4, that central canal is still relatively rounded, and you can see that there. At the level of the L4, L5 disc, let's watch what happens. That anatomy is completely distorted now. Now, this is a diseased disc segment, and what's happening is there's going to be increased stress on all the other supporting structures around the central canal. At that segment level, you see ligamentum flavum now buckling up, and some people say hypertrophied, but it's usually more a buckling of the ligamentum flavum at this level. And you can see that the central canal is no longer circular or round, but more like L5, where it is more triangular in shape. And this is a distortion in the usual anatomy of the central canal. That's the lamina. And if you look at the interlaminar space over here at L4, L5, this is where you would want to approach if you were to go in with a needle in the interlaminar space at L4, L5. There's really not much space there. If you came in from the side of the distorted thecal sac, you might have to enter even more horizontally. Otherwise, you would end up directly into the disc itself, which is possibility. So it's important to bear in mind as well what the anatomy looks like at diseased levels, and best to try and avoid those if you can. And then now go back to L5, and you can see everything sort of restoring its natural order around central canal over here. But at L5, the bony margins of the central canal are triangular, as Dr. Bernard showed us. So once again, running upwards just very quickly to show you guys this. Once you're at the level of the transverse processes, you are usually at the level of the lamina. But once you go upwards and you start to see facet joints, you're usually at the level of the exit foramen. Okay, we return to the lecture now. Okay, so remember, there is a major pitfall here in that when we look at lumbar MRI spines, the axials are performed parallel to the discs. When we are doing our lumbar sonoanatomy, the cranial caudal tilt of the probe may not be exactly the same as the lumbar axials as well. So just so I have a good mental image of where you're going. Now, you can also get into trouble when you're dealing with patients with who have degenerative spines. One of the things is there's loss of intervertebral disc space as well as the interspinous disc heights. There's almost no space between the spinous processes over here. And you can see how that epidural space is also very narrowed, because there is also generally loss of fat in an older individual. So compare a 52-year-old with a 36-year-old spine. You can see that the epidural space gives you much more room for maneuvering compared with an older individual. So that brings us to a question of dry taps in spinal anesthesia. So as I showed you, you want to go slightly lower than L2 level because you want to avoid the conus medullaris. And Reynolds suggests to use the lowest palpable level. So usually L4-5 or L5-S1. But with these levels, you get a 10% incidence of dry tap. And then you usually get more successful if you go up one level after that. Why is that? The reason is this, right? The volume of the CSF declines as you go lower down the lumbar spine. At L4 and L5, you've really got a small amount to play with. And so as you go backwards one level, you increase your chance exponentially of getting CSF. Be careful as well, because the spinal canal and the thecal sac have different shapes at different levels, as we mentioned. At L3-4, it looks a bit more oval. L4-5, it starts to become a bit triangular and about 10% smaller than L3-L4. So you only really have about L3-L4 and L4-L5 to play with if you were to avoid the conus medullaris. The other problem is that we perform dry taps, spinal taps with the patient in lateral decubitus position. And so if the needle is non-dependent, so you're inserting it from the non-dependent portion into the spinal canal, then the CSF has to fight against gravity. And so you now have a combination of anti-gravity flow and a distorted shape. So don't make your life more difficult by going at a level where there is problems with a degenerate disc, for example. The question is then, if you use a larger gauge needle, would you potentially cause more distortion of the thecal sac as you enter, or are you safer doing it with a small gauge needle? On to the topic of subzero space, and we're coming to the end of this talk. Now, remember, the dura mater and the arachnoid mater are very tightly coapted, and you only have a potential space unless it's been damaged. and then they delaminate. So you cannot resolve the two spaces on a normal MRI or CT scan. But if you perform an injection, and this is under fluoroscopy, and you can see puddling of contrast, but it does not follow the nerve root out into the extraforaminal spaces. Be very careful, because you might not be in the epidural space anymore. Or as Dorothy says, we're not in Kansas anymore. And following this paper, reported in 2007, CT scan was performed, and you can see layering of the contrast within this potential space. It does not flow anywhere, because if you remember, the dura does follow the nerve roots a little bit towards the exit foramen, but then they fuse with the epineurium of the nerve root. In other words, they don't flow out into the extraforaminal spaces like we do with the epidural space. And that's why you can see gathering of contrast just in a dependent part of the spine, for example. It does not even have to be dependent, because as Dr. Miguel has shown us, the subdural space is not a complete space, and it's just a rent in and causes a rent in the between the dura and the arachnoid, which results in a potential space which can be filled by this contrast fluid. In an successful epidural injection, you can see the fluid within the epidural space. Here, it's clearly deep to the fat of the epidural space. It's somewhere deeper in, so it has to be subdural in location. If you had a successful epidural injection, an interlaminar approach down here, you would see that this triangle filled with contrast and spilling across and dissecting circumferentially around the dura, and sometimes also following the nerve roots outwards. And that is an epidural injection. So if you're not in an epidural space, then you can only be in two other spaces: spinal, which is intrathecal, or the subdural space. And with the spinal injection, if you were to give anesthetics, you end up with a cauda equina blockade or saddle anesthesia. But with subdural, it is unpredictable. Number one, the effects may not be fully apparent for a few days even. You can make the pain even worse. Then patients may have spinal headache, and some people say it may predispose to arachnoiditis. So the key here is that subdural contrast, as opposed to intrathecal, appears more opaque, and it stays there if you were to perform a fluoroscopy guided injection, because you'd have no CSF dilution or runoff in the subdural space. It just gathers there. So the other tip I would give you is, if you withdraw the stellate from say a 22 gauge needle, and you see CSF coming back as well, because you can get CSF leaks in the subdural space, then stop, right, and reposition the needle to get back into the epidural space. And that's the only way I think that we can tell on a ultrasound-based injection technique. So just to quickly summarize, I wanted to show you the real-world MRI and CT anatomy, as well as the limitations that we face in assessing the interlaminar space especially. And remember that the MRI cuts are much more thicker than our ultrasound beam itself. The ultrasound is only 1 to 2 millimeters. The MRI cuts usually about 3 millimeters, 4 millimeters in thickness. But have these landmarks in mind when you're doing your ultrasound. If you see transverse processes, you're likely to be at the pedicle level. If you see the facets, you're likely to be at the foraminal level. The lumbar nerve roots run in a inferior and caudal oblique course. The interlaminar space is seen between the facet and the transverse process. And if you encounter a dry tap, then go up one level. If the stellate shows CSF, stellate withdrawal then reveals CSF, then withdraw gently, reposition for an epidural injection. And that's the end of my talk. Thank you.